Well, again, welcome everybody. My name is Dewayne Davidson. As I mentioned earlier, I'm actually a clinical pharmacist. So I've been practicing as a ambulatory care pharmacist for about 13 years now. And my specialty is actually in diabetes management. So I'm also board certified in advanced diabetes management. Today, I'm going to talk about the intersections of chronic illness and about managing diabetes in the landscape of hepatitis B and hepatitis C. So we'll just kind of get going here. I don't have any conflicts of interest to disclose. And I'm going to be using probably switching back and forth between brand names and generic names. I'll try to use generic names of drugs when they most commonly come as generic, but I may use brand names here and there just to make it a little bit easier for just name recognition. All right, so our learning objectives today are three. So I plan on reviewing some pathophysiology of diabetes and liver disease. So we're going to kind of kick it old school here and kind of talk about the different stages of diabetes, how we get there, what's all involved in that. We'll also talk about liver disease and its progression. And then we'll talk about the links between viral hepatitis and then diabetes and how they interplay with each other. And then finally, we'll discuss the clinical impact and management strategies for hepatitis B, hepatitis C, and diabetes. So kind of bring it all together and how are we going to manage this? All right, so bringing it back. So when we really think about the liver is really an amazing organ. So really we think of it as kind of our first line of defense against toxins. So it's really getting rid of waste and breaking things down for us. But it's also, I like to think of our liver as our gas tank. So one of its major functions, in addition to getting rid of toxins, is managing glucose, surprisingly. So its real big function is when we eat, and I'll kind of work through this slide here. When we eat, a lot of that sugar is actually stored in our liver to be used later on during the day when we're not eating or even overnight. And so really what's happening here is this homeostasis that's happening where we're trying to keep blood sugar normal. Again, this is in patients that don't have diabetes. And we'll kind of talk about as we go through this, what happens and how we get to a diabetes state, really meaning high blood sugar. So when we eat, our pancreas senses this increase in sugar, and our body is going, hey, we need to get rid of this somehow. Where are we going to put it? So our beta cells start producing insulin. So this is following the yellow line here. And part of that goes directly into the liver where it converts this glucose in the bloodstream to glycogen. And glycogen is the storage molecule of glucose in our liver mostly, but also in other cells. Similarly, with this insulin, it's also used in a couple other places, kidney also, but muscles, the other major area where insulin and glucose are combined together to form glycogen. And then fat also uses insulin to convert glucose into triglycerides, which is where glucose is stored in our fat cells. So when this process is normally working, then our blood sugars stay the same, and it's a very complicated process. So this really oversimplifies what's happening here, but this really helps us stay at a very steady level. And then on the flip side, when our sugars start to go down, maybe we ate earlier, so we've stored up all that sugar. It's getting around lunchtime now. You're probably getting hungry. But we're able to keep going. How does this happen? Well, so right now, the opposite is happening. Our sugars are starting to go down. Our pancreas is sensing that. And so it releases a different hormone called glucagon. And the purpose of glucagon is to convert glycogen in our liver back into glucose, which is then released out into our bloodstream. So you see this is kind of a little figure eight pattern, and this is happening all throughout the day. As we eat, it goes into storage. When between meals, it comes out of storage and back and forth, just depending on how our body is demanding that energy. So that kind of sets the basis of where we're at. When we talk about diabetes, this is where things start to go wrong. And so I really like to use this figure. There's actually several of them out there, but it's called the ominous octet. This was came out by Dr. Ralph DeFronzo. He's a world-renowned diabetologist. He actually practices and researches here at UT Health San Antonio. But really, it was just bringing together all the dysfunction that goes on in our bodies that ultimately ends up in hyperglycemia or high blood sugar. Prior to this, it was really focused on three things. It was really insulin resistance, our body's inability to slow down glucagon secretion, as well as the pancreas's impairment of producing insulin in the beta cells. And so now we know more about diabetes. And in 2009, he coined this ominous octet. And I'll kind of go through each of these little steps here. We'll just start up here in the top left and really talk about how each of these have an interplay in our body that ultimately results in hyperglycemia. So if you start here in the intestine, really what happens here in diabetes or what's going wrong is we don't have enough production of GLP-1. And GLP-1 is important it's a signaling hormone released from our guts and incretin. And what it does, it tells our pancreas, hey, we got sugar coming in or not enough sugar. And so that's really what's pushing our pancreas to produce insulin when we need it. And so when as well as glucagon, shut down the glucagon production and vice versa. So when the incretins aren't working in the intestine, then we wind up with hyperglycemia or high blood sugar because the signal going to our pancreas saying, hey, make more insulin to get rid of the sugar isn't happening. And the signal that's telling the pancreas to stop making glucagon, which makes our liver make more glucose, also isn't working. So it's kind of this downstream effect that's happening that ends up with high blood sugar. Our brain, so there's definitely lots of neurotransmitters in our brain that tell us, hey, we're full, stop eating. When that's not regulated well, then we tend to eat when we don't even feel like we need to eat. And so there's a problem there. The classic pancreas issues here. So beta cells, again, that's where insulin is produced. If we don't have enough beta cells in our pancreas and we're not producing enough insulin, and so without enough insulin, then we have high blood sugar. Similarly, we have increased glucagon secretion. So the body is saying, hey, we need to try and get rid of or stop. We need to get rid of the insulin. I'm sorry, we need to get rid of the glucose. I guess it's really complicated. And so we really need to stop making glucose in the liver. And there's some dysfunction there when our pancreas isn't getting the right signals. Usually these kind of work in lockstep with each other. When you have beta cell production of insulin, then you have a decrease of glucagon. But when you don't have that increase in insulin, then you don't have the decrease in glucagon happening. And so we have this kind of pedal to the metal effect of more sugar being made in our liver as well as glucose not being stored as glucagon. And then coming back around here to the kidney on the lower right-hand side, as our body has more sugar and we're trying to get rid of it, our kidneys try to get rid of it, but at the same time, it's our body is sensing, oh, hey, this is energy. Like, why are we getting rid of this? And so the kidney kind of steps in and says, okay, we're going to start keeping some of this glucose too. And so ultimately, it's adding on to the pile of glucose that's in our body that needs to be disposed of somehow. Moving on around to fat. So again, without insulin to drive glucose into our fat cells, then we have, again, the opposite happening. The fat is releasing triglycerides, which are then converted into more glucose, again, leading to hyperglycemia. Our muscle tissue, because it's not getting insulin, is also not taking up sugar. And so again, it's using what it can, converting, using fats as an energy source, but also not taking up glucose. And several of these things here also lead to insulin resistance. So this is kind of a byproduct of having so much insulin on board that we become insulin resistant. And then finally, again, we've kind of talked about how the liver works with this process. And so when you have all this other dysfunction going on, particularly with the pancreas, and you also have dysfunction in the liver. So the other thing and we'll circle back around to this diagram here, but you'll notice these kind of abbreviations here around the outside. And these are actually the different drug classes that we can use that target these different dysfunctions that are going on in this ominous octet. So like I said, we'll circle back around to this slide. So when we talk about the progression to diabetes, really it starts out with insulin resistance. And when we talk about insulin resistance, basically we're saying, hey, our pancreas is spitting out insulin, trying to get rid of this glucose, but the rest of the body, the liver, the fat tissue, the muscle tissue saying, hey, I'm full. I don't have any more room for this. So I'm going to start putting up roadblocks. And so we have more glucose in the system. And so what is the pancreas trying to do? It's trying to make more insulin because it's saying, hey, I need to get rid of this. And so you see on this blue line with this initial insult of so much sugar or so much glucose needing to be disposed, you have this increase in insulin production. And so that kind of puts us in our pre-diabetes state where we have high insulin production, high insulin resistance, and we're trying to get rid of glucose. And that's this red line here. And so during the pre-diabetes stage, this is where we're starting to have this impairment of too much glucose coming in, too much insulin resistance, high glucose happening, which ultimately results in diabetes, where our body is just totally at a dysfunction now and we can't manage the glucose coming in. Putting this together, so diabetes and liver disease. So again, we've kind of talked about this initial insulin resistance and the role here in the pancreas to produce more insulin. Well, again, we talked about earlier just the more fatty acids that are coming out and the triglycerides that are being made, which also unfortunately have this bad feedback loop, which are causing beta cells not to produce more insulin. And so the pancreas is trying to make more, and at the same time, it's being blocked. And similarly, what's going on in the liver is we have fatty deposition of triglycerides or glycerols that are happening there. And so now we start to have fatty liver or fatty liver disease, or there's other names for it. But again, as this continues to happen, then we end up having diabetes. But then on the flip side, diabetes continues to contribute to this progression of liver disease. So we have the insulin resistance, we have more fat being deposited in the liver. It's causing inflammation, which is now causing fibrosis. And now we get to NASH or MASH, and then ultimately cirrhosis, and even potentially hepatic cellular carcinoma, and then ultimately death. So it's this spiral loop that we get in with diabetes and liver disease. And oftentimes you'll see patients that have diabetes and you run a chemistry on them and they have elevated liver enzymes. And you're like, hey, what's going on here? This is what's happening. This fatty liver that's starting to be created because of the high sugar load and the insulin resistance. This is the initial signs you're probably going to start to see, at least on a lab panel, of, hey, we've got initial stages of fatty liver happening. And then we go down this pathway of, okay, let's go get an ultrasound or some other testing, and sure enough, it comes back fatty liver. So that's the first part. And then when we talk about viral hepatitis and liver disease, again, something similar. So we have our normal liver, but then when we have an infection with a hepatitis B or hepatitis C virus, it again causes this inflammation in the liver that causes destruction of the hepatocytes, again, leading to more fibrosis, and then ultimately cirrhosis and hepatocellular carcinoma. So kind of again, a similar pathway. And then when you put diabetes on top of this, it's really like adding gasoline to a smoldering fire. So if you think of hepatitis B and hepatitis C as a smoldering fire in the background, that's just slowly destroying the liver, and then you're adding this insult of more sugar, more sugar, more sugar. It really pushes the progression of liver disease quickly to cirrhosis if we're not monitoring it and managing it. I also want to talk about hepatogenous diabetes. This really isn't a term that's used in the United States a whole lot, but it's a different type of diabetes that we also need to be cognizant of. And it's actually the opposite problem. Well, it's related, but what's happened here is that the liver has progressed to cirrhosis, and it could be due to hepatitis C. So you see that here on this diagram. It could be due to liver disease, it could be due to autoimmune disease, but you ultimately end up with cirrhosis. And through this whole time, the patient doesn't have overt diabetes or overt diabetes symptoms. But at some point, when the liver becomes so cirrhotic, and if you think about, we talked about how the liver is kind of this sponge that soaks up glucose, extra glucose, it gets rid of it when you need it. When you get to cirrhosis, that ability of the liver to take up sugar, that sponge is now basically a hard rock. And so the ability of the liver to take up sugar is greatly diminished. the insulin within the cirrhotic liver just passes through, and so now you have all this insulin floating around in the body instead of it being partly used in the liver, again leading to hyperinsulinemia and then insulin resistance. And so compound that with obesity, and we really have this recipe for a diabetes disaster that's happening. So the treatment for hepatogenous diabetes is a little bit different. And so that's kind of why I want to bring this up. So when we talk about treatments for diabetes, we're also kind of keeping this in mind. So just kind of bring it all together. So starting from the top, it could be obesity is kind of the initial target, but it can also just be systematic inflammation, again, from hepatitis C, hepatitis B, that ultimately results in insulin resistance, which then results in fatty liver and its progression, as well as diabetes. And it's just this vicious circle and vicious cycle of worsening liver, worsening diabetes, poor control. And so we really need to work to reverse this, stop it, and try and reverse this as much as possible. So just again, summarize the clinical impact with hepatitis B, hepatitis C, and diabetes. So interestingly, hepatitis B, so it disrupts glucose regulation by directly damaging hepatocytes. And so over time, as you continue to damage hepatocytes, and you have the less ability of the liver to manage glucose. Hepatitis C works a little bit differently. So hepatitis C actually in the hepatocytes blocks the insulin receptor. And so within this cell, the liver, the hep C that's infected it says, nope, sorry, insulin, you're not going to come in here through the insulin receptor. And so it just kind of pushes it out. So again, leading to more insulin, we're not taking up glucose, again, leading to steatosis and fibrosis, and ultimately increased diabetes. And you'll know that with patients with hepatitis C, they do have this increased diabetes risk, sometimes 20 to 30% increase. So a lot of times you'll see this in conjunction with hepatitis C. We already talked about how diabetes accelerates progression to cirrhosis, both in hepatitis B and hepatitis C. And also diabetes alone increases hepatocellular carcinoma risk. And then cirrhosis further increases insulin resistance, which then leads to more diabetes. And again, this vicious cycle and circle. So how do we reverse this? What do we need to do? So first thing really we should think about is adequate screening. So, and the guidelines kind of talk about this bidirectional screening, meaning for patients that have viral hepatitis, because we know it can lead to diabetes, we should be screening them periodically for diabetes and start to manage that. So particularly when we talk about hepatitis B, when we're just monitoring it, we're not treating it, we're monitoring it, we should be screening for diabetes at least annually. And then on the flip side, for patients that have diabetes, transmission of hepatitis B can be high. They can also contract hepatitis C. And so even for them, we should be periodically checking for hepatitis C, because again, together is going to quickly lead us to cirrhosis and end-stage liver disease. Infection control, definitely want to vaccinate hepatitis B, and this is true for all diabetics, especially if they're under age 60. This is where the biggest benefit is, but certainly if you want to vaccinate a diabetic over the age of 60, there's no problem with that, and we should, especially if they have other liver disease. Definitely treat hepatitis C. So again, if we can get rid of the hepatitis C and the inflammation that comes along with it, then we'll have better diabetes control. Other things to remember here for patients with diabetes and hepatitis B is that we shouldn't share insulin pens or needles or glucometers. These viruses can live outside of the body for weeks, if not up to a month. So it's out there. When it comes to treatment, certainly first thing first is lifestyle modifications, so diet, exercise, and weight control. This is really what's going to reverse this process. And then there's really no clear diabetes treatment guidance. We'll talk about kind of what some of the preferences are, and this is starting to change. And I think in the 2025 guidelines, we really start to consider liver disease and diabetes. And so we'll discuss this a little bit further on here. And then for patients that have diabetes that are on a hepatitis C treatment, probably want to closely monitor their blood sugar because the treatments that we use do improve glycemic control. And so if there's particularly on insulins, you could risk hypoglycemic events. Probably not so much if they're just on orals. Again, going back to lifestyle modifications, the importance of physical activity. And so There's just so much benefit here, even just a little bit of exercise. The sedentary lifestyle for a patient with diabetes and hepatitis C or hepatitis B is not doing them any favors. Exercise here helps reverse that. It gets the body moving to take up that extra glucose to actually improve insulin sensitivity or decrease insulin resistance because these cells want the sugar. So if you think about if I'm not moving, I'm not doing a whole lot, my muscles really don't need a whole lot in terms of energy. But if I'm out there walking, doing some physical activity, I'm burning energy. And so my muscle tissue is saying, hey, I need more sugar to keep going. And so when we do this, when we exercise or do some sort of physical activity, we're now telling the body, hey, I have a need for glucose. Let's reverse this process. Let's get that glucose out of our bloodstream into where it needs to be. And again, exercise doesn't need to be a whole lot. So they certainly recommend 150 minutes a week, but anything, if you're doing 0, 5 minutes will help tremendously. I've seen this in diabetic patients where even they're on monitors and or continuous glucose monitors. And if you watch them, especially type 1 diabetics is really more profound. If you watch their blood sugars, they go for a walk, they can potentially have hypoglycemia just going on a walk if it's a fairly strenuous walk because of that increase in glucose and the improvement in their insulin sensitivity. All right, moving into diabetes pharmacotherapy. So this might be what everybody's wanting to know, like how do I manage diabetes in these various conditions? And so we're gonna kind of fill out this little table here real quickly. And so again, going back to our hypoglycemia or ominous octet, I want you to notice here GLP-1 receptor agonists. So common names for this are Victoza, Wegovy, Ozempic, Mounjaro, even Zepbound. So these are all GLP-1 receptor agonists. And when you look at this diagram, GLP-1 receptor agonists actually hit 6 of the 8 pieces that are dysfunctioning in this ominous octet. So if you think about how do I want to manage diabetes in general, GLP-1s are great. They cover a lot and they do a lot. But that leaves us down here in the corner with these two things. We have fat dysregulation and we have kidney reabsorption of glucose. Fortunately, we've got drugs for those too. So our SGLT2 inhibitors, the class that came out in 2013, is now proven has lots of benefits in cardiovascular disease, preserving kidney function over the long term. This would be a great add-on if we need to manage diabetes and our GLP-1 just isn't cutting it. And then lastly, our TZD has an important role in insulin sensitivity. So you notice here that our TZD, thiazolidinedione, or a common name for that is pioglitazone. It's really the only drug that we have available now, increases insulin sensitivity. So here it covers kind of this original triumvirate of what goes wrong in diabetes. So if you're putting together the best diabetes regimen, kind of looking at this diagram, it would be a combination of a GLP-1 receptor agonist, an SGLT2 inhibitor, and probably a TZD, a thiazolidinedione. Okay. And then if that's not enough, then there's some other things that we can add on here. So when we talk about hepatitis B and hepatitis C, we should also talk about drug-drug interactions with our diabetes agents. Fortunately, there aren't any. So the drugs that we use for Hep B treatment, tenofovir and entecavir, no drug interactions with our commonly used diabetes medications. Same thing for hepatitis C, Mavorixafor, Epclusa, Harvoni, no drug interactions. But again, like I mentioned before, with hepatitis C treatment, you do get improved glucose lowering. So you can have a hypoglycemia or low blood sugar event. So just you want to monitor that. So again, bringing this all together, I've kind of broken this down into, again, a normal patient without liver disease, pretty much use anything. We generally, at this day and age, we avoid sulfonylureas because they just push out more insulin out of your pancreas. But if you think about where we're at in the disease process, your pancreas is already pooped out. So 50 to 75% of the beta cells are no longer there by the time you're diagnosed with diabetes. And again, I'm focusing around type 2 diabetes. So really the utility of sulfonylureas is not there anymore. Plus it causes weight gain and low blood sugars. But the other agents are great. And we talked about kind of this triple therapy group would be great. Dr. DeFranzo, he would argue for a quadruple therapy of metformin plus a TZD plus a GLP-1 plus an SGLT2 inhibitor. Again, these drugs are very powerful. GLP-1s can lower A1C by 2%, metformin 1.5%, SGLT2 inhibitors 1% on their own, and even TZDs another one. So when you're putting that together, you can lower somebody's blood A1C by 6 percentage points. Absolute. When it comes to what we used to call a non-alcoholic fatty liver disease, or now it's metabolic associated steatotic liver disease, sorry, or metabolic associated steatohepatitis is a new terminology for NAFLD and NASH. Some drugs are actually proven to be beneficial, and I've kind of highlighted these here in green. So depending on what stage of liver disease you're in, the preferences are, again, GLP-1s because they help with weight loss. That helps reverse this process, but they also reduce steatosis by 25 to 40%. SGLT2 inhibitors have also been shown to reduce steatosis by 20 to 30%. A lot of this is due to reducing insulin resistance, and same with TZDs. And then when it comes to kind of the next stage, MASH, you have this additional resolution of MASH in 25 to 35% of patients with TZDs and 20 to 40% with GLP-1s. And so when you look at the diabetes ADA guidelines, they really focus on these ones that I've highlighted in green. But then when we get to cirrhosis, then things start to get a little bit, we got to be careful and more cautious. And so I've noted here, yes, in compensated cirrhosis, TZDs and GLP-1s are okay, but again, we got to be careful. Insulin is starting to become more of a treatment of choice when you get into the cirrhosis, and especially with decompensated cirrhosis, then insulin is your treatment of choice. And I put a little negative here for cirrhosis because really want to think of going back to hepatogenous diabetes. So in those patients, you don't really need more insulin. So that's kind of why I put a little caveat, if I could put a little star there. If it is hepatogenous diabetes, really it's more about diet modification and physical activity than it is adding on insulin there. So again, just kind of bringing this all together. This is what the diabetes algorithm looks like. We've already talked about this quite a bit, but really you want to focus here on weight management. And so your GLP-1 receptor agonists are going to be your first line agents. And then if you really want to focus on glycemic control too, then adding on, like we talked about, pioglitazone or some of the other agents. And they actually, in this update in 2025, they actually talk about MASLD and MASH. And we've already talked about the benefits of GLP-1s. This dual GIP and GLP-1, that's tirzepatide or Mounjaro. Adding pioglitazone, that's a TZD or some combination of those. And again, this is kind of a new one in the 2025 guidelines, again, kind of looking at the different stages of liver disease and probably what we want to use and when we want to use them. So just here is a reference. So lastly, benefits of treating Hep B and Hep C. So Hep C, sustained virologic response, reduces diabetes complications. So this is proven in the literature, including cardiovascular disease, end-stage renal disease, and retinopathy. So definitely want to treat hepatitis C. Hep C also reduces insulin requirements, which also has about a 0.5 point lowering of A1C. So better glucose control. Really doesn't change how much oral medications or injectable medications other than insulin. It's just a little bit. And then hepatitis B treatment also improves lipid metabolism and ASCVD outcomes. So again, when we talk about diabetes, these are these complicating factors with long-term diabetes. So the more we can treat or manage Hep C or Hep B, the better outcomes our diabetes patients are going to have. And then metformin, we really haven't talked about metformin a whole lot. It's kind of our original go-to drug, but we kind of have better things now. Again, metformin has shown to reduce hepatocellular carcinoma risk in patients with hepatitis B. So again, metformin would also be a good choice. So just to summarize here, viral hepatitis and diabetes compound risk to cirrhosis through inflammation and insulin resistance. We talked about how that's kind of this vicious cycle and why we really need to treat Hep C or treat and monitor Hep B, as well as reduce and reverse inflammation and insulin resistance so we don't progress to end-stage liver disease and cirrhosis. And then also vaccinating is also important for our diabetes population to prevent transmission as well as prevent complications. That's all I have. So any questions from the audience?